Good afternoon, everyone. I know this is the most resilient period because post lunch, I think we'll test our resilience, whether we can sit with our eyes awake. But I promise you, what we have is an exceptional plenary, which includes a lot of practitioners from Indian states, which include international guests. And what we would be discussing is something which is again very interesting. It combines policy and it combines implementation. Uh, so, welcome back once again. Our session today is from volume to value, and it focuses on strategic purchasing, which is at the intersection of financing, service delivery, and governance. And we have been speaking about strengthening and building resilience in health systems. And strategic purchasing is how we operationalize that strength by aligning resources, providers, and ultimately looking at how we are measuring health outcomes. India in last several years, more so in between last 7 years, has been implementing Ayushman Bharat reforms and has undergone a huge transformation. We are definitely moving towards a continuum of care where there is a network, a nationwide network of health and wellness centers. At the same time, we are providing for financial protection. Uh, Ayushman Bharat, as most of you would know, provides a health insurance cover of 500,000 rupees, a comprehensive hospital care cover, and covers more than 550 million people. So that's a huge transformational scale that we have. Over again, last 8 years, we have created as a country a network of 30,000 hospitals, both from the public sector and private sector. And that's a huge purchasing power that we have as a country, where now we need to see, besides just purchasing health, how can we start influencing the provider behavior? We also have the Ayushman Bharat Digital Mission, which plays a very, very important role in creating an integrated, coordinated health service delivery system. However, as this flagship program of India matures, we need to start to think about moving from utilization to looking at how we measure outcomes. Like all countries which started insurance, the initial focus was benefit package design, empanelment, focus on utilization. But now that we have stabilized, we need to see that how do we move to use this purchasing power to shape provider behavior? How do we get more cost discipline through smarter payment designs? Most importantly, what we also heard in the morning presentation is that how do we integrate the public health priorities? We still operate in a very siloed approach. So, how do we really bring that continuum together? And again, the most important is that how do we measure outcomes? So, the next 5 phase is far more complex. And today, at the GLC conclave, we are bringing together leading experts from India and Thailand to unpack this critical question. It is truly a great privilege that we have been able to co host and co create this session with the National Health Security Office of Thailand, a country that has achieved universal health coverage for its population and also has demonstrated that over a period of time, you could use purchasing to move to outcomes. And I'm sure it's been a learning lab for a lot of countries across the world. We, of course, have a very distinguished panel from our states, senior policymakers, both from states and national level. And with this, I would introduce our panelists and I would request our panelists to please join me on the stage. Um, First of all, it's my great pleasure to introduce our keynote speaker, Dr. Thanasak Tumbantu, who's director at the Thailand's National Health Security Office. With a strong background in clinical care and health policy from the University of Edinburgh, Dr. Thanasak has been closely involved in shaping Thailand's transition from coverage to value. Thank you so much. And from everyone in India, Kapan Khap. I now call Dr. Pankaj Arora. Dr. Pankaj Arora is from National Health Authority. He's a senior public health leader, and I'm sure almost all of you would have met him during last 5 to 6 years, and he's been instrumental in shaping India's large health programs. At the NHA, he's a director and he's driving the nationwide rollout of Ayushman Bharat Digital Mission, enabling integration between central and state health systems. Thank you, sir, for joining us. It's again a privilege to introduce a leader who has been at the forefront of India's most mature health systems, Dr. Vineet. Dr. Vineet is an Indian Administrative Services Officer and a medical doctor, and he currently heads the Tamil Nadu Health Systems Project, where he's driving improvements in access, quality, and system performance. Welcome, sir. Again, it's a real pleasure for me to introduce someone I've had the opportunity to work closely with, Ms. Archana Verma. Ms. Verma is an Indian Administrative Services Officer and an engineer by training and serves as the CEO of State Health Agency Sachis, driving the implementation in Uttar Pradesh and brings a strong systems approach to public service. Thank you, ma'am, so much for joining. Dr. Mahesh, I'll request you to join us, sir. He serves as a deputy director at Suvarna Arogya Suraksha Trust, the nodal agency responsible for implementing PMJ and Arogya Karnataka. He's a senior anesthesiologist and has nearly 20 years of experience and brings a unique blend of clinical expertise and public health experience. Thank you, sir. And completing our panel, we have Dr. Sudha Chandrasekhar, a medical doctor, a health economist who has played a number of roles in academia, state government, at national policy, and most notably with the National Health Authority, where she contributed to policy design and provider engagement. So thank you, everyone. We know that we were a little bit delayed, but we'll try to make up. So we have a combination of presentation and speaker comments and reflections. We do want to have an engagement, so there will be a QR code which will soon appear. So that you can share your reflections, you can share your questions to the speakers, and as we go along, then we will be able to take these. With this, I'll not take too much of time. I would request Dr. Thanasak to make the presentation on Thailand's journey. And honestly, there's so much to learn from Thailand, but we decided that we are going to focus on 3 broad areas of capitation, DRGs, and how Thailand started moving towards value-based care. So I welcome Dr. Thanasak for his keynote presentation.
Sawasdee krap. Namaste. Good afternoon, everyone. I am Thanasak Thamatu, the Director of the National Health Security Office, Region 13, which is covered Bangkok area. So today, we will discuss a critical transition for publicly funded scheme, moving from paying for volume to strategically purchasing for values and outcomes. So I will share Thailand's journey over the past 2 decades, highlighting how our universal coverage scheme use strategic purchasing, not just increase spending, to improve quality, control costs, and deliver better health outcome for our citizens. So I will start with the first part. So let me begin with a fundamental truth. Health spending alone does not guarantee better outcome. So here in this slide, you can see that if you look at the data from 2021 to 2022 from the World Bank, you can see a strike contrast. For the US, they spend around 70% of its GDP on health and achieve a life expectancy of around 77 years. And in Thailand or Malaysia, they spend just over around or maybe around 5% of their GDP and achieve relatively comparable outcomes, such as life expectancy, immunization rate, and effective service delivery. At the same time, financial protections remain strong. Only about 2% of the population experience catastrophic health expenditure, compared to around 7% in the US. So this is just the first truth that having money, it's one thing, and managing money is another critical factor that we need to think about strategic purchasing. So to manage this system, Thailand Universal Health Coverage Architecture rests on 3 schemes. The civil servant medical benefit scheme, around 70%, 7% of our population. Social health insurance, around 18%, and the remaining 70% belongs to the universal coverage scheme managed by my office, the NHSO. So as a strategic purchaser, funded by general taxation and supported by a strong primary care system of nearly 10,000 sub-district health centers acting as gatekeepers, the NHSO play a key role in reducing medical poverty. So about the result, we can increase the population coverage from around 70% in 2000 to 100% just right after the reform. And for the service coverage, it grew from 43 in 2000 to around 82 in just 2021. And when we can reduce the catastrophic health expenditure from 2.2% to around 0.2. And in terms of financing source, in the past, we used to rely so much on our pocket or private source of funding, but right now, majority of the funding in health system, around 90%, come from public funding source. Actually, even you can see that Thailand have an overall good performance, but actually there is some discrepancy within like its universal health coverage scheme here. You can see on the left-hand side, the civil servant medical benefit scheme operate with an open-ended budget, rely heavily on fee for service payment for our patient. So the more they provide service, the more the government have to pay for the service. For the inpatient, they use the DRG, but multiple DRG rate, favoring a big hospital and have no gatekeeping function. So this passive model leads to higher cost, around 18,000 baht per capita on the left-hand side. And if you look at the right-hand side, we have the universal coverage scheme use a closed-ended budget, primary care gatekeeping function, age-adjusted capitation, and single DRG with global budgets and centralized procurement. This strategic approach delivers comprehensive care at just around 3,800 baht per capita, or around 4 times a smaller amount of money. So we can achieve quite the same benefit package with a lower investment. So the lesson is pretty clear on how you pay determines performance as much as how much you spend. So next, we're gonna talk about the payment mechanism, which is one of the component of strategic purchasing. So if you look at the payment spectrum on this slide, fee for service places financial risk onto the payer side and incentivize over provision. At the other extreme, capitation shift the risk from payer to provider, make them like cost conscious. So it can control cost, but risking under provision. And DRG in the yellow square, it's in the middle, balancing risk by paying standardized rate for acute conditions. Because every method has behavioral trade-offs, effective strategic purchasing requires combining them so they can counterbalance one another. So as of now, the NHSO manage a diversified payment model to balance equity, cost control, and quality. Around 29% of our budget is allocated to capitation, forming the foundations for most of the primary care in the country. Another 28% is paid through DRGs, standardized hospital admission. Meanwhile, 35% is directed through targeted fee schedules to support high priority or high cost service that the primary care center might not provide because of the high cost. And the remaining 8% support national prevention program and local matching funds. Thailand's universal coverage scheme builds on lessons from the social health insurance system for formal sector employees. Early capitation rates were calculated using simple probability models. For example, like estimating expected hospital utilization and average cost per visit. Initially, low utilization led to provider profits, which help accelerate the adoption of the capitation. Under the UCS scheme or Gold Card, capitation has been used since its inception to fund outpatient curative and preventive services, shifting from supply side line item budget in the past to demand driven per capita allocation. Oh, sorry. The UCS applies a comprehensive closed-ended prospective capitation rate based on real cost data from representative hospital in Ministry of Public Health and adjusted for population size. Each year, the capitation budget increased by approximately 6%, reflecting benefit expansion, inflation, and expected change in utilization. However, the biologic risk distribution in each district might be different or maybe disproportionate. So we need to do two things just to make capitation work. Here, the first measure is we try to pull a sufficiently large population to spread the biologic risk and achieve economy of scales, allowing more efficient investment in workforce, medicines, and technology. For example, like each catchment should have like 50,000 or more than that population. Second, since the risk cannot be evenly distributed, so the duty of our office, our accountability, is to adjust capitation to compensate for the biologic risk. At the national level, we use age-adjusted capitation. You can see on the left-hand side that this is the point that we have to multiply with the number of population. So each catchment that has maybe elderly and a lot of children, they will get more money in terms of like the capitation rate. For example, the national average capitation rate is around 1,488 baht for 47 million people. But in Bangkok, you can see maybe the purple line up there. The capitation rate is higher than, higher than like the national average, around 70 baht. This is because of the population that may have more people who are elderly and children. And this adjustment also applied to other 13 provinces with similarly high biologic risk. And in Bangkok, we also do additional layer of reallocation, or we call differential capitation. So because unlike in the rural area, where each catchment may cover around 50,000 people, but Bangkok rely heavily on private provider, maybe small clinic, which can only accommodate around 10,000 or 12,000 population. So this small risk, the smaller risk pool increase the likelihood of financial strain if a clinic served a disproportionately high number of complex patients. To address this, we adjust capitation using a composite index, around 60% from Chow Song Comorbidity Index, reflecting the risk of 23 disease groups and 40% from age. However, this adjustment currently applies to only 15%, you can see in the square down here, of all the outpatient budget, while the remaining 85% remains a fixed rate. As a result, it is not yet sufficient to fully offset uneven risk distribution. Moving forward, next year, we plan to expand differential capitation to cover 100% of the outpatient budget in Bangkok. And we will also incorporate utilization rates and a more granular data-driven disease weighting index tailored to Bangkok population specifically. For the reflection about capitation, capitation offers three key advantages for the health system. First, it provides strong cost containment by encouraging cost-conscious behavior such as the use of generic drug or rational prescribing or avoiding unnecessary visits. Second, it reduces administrative burden as it eliminates the need for claim processing and transactions audits. For example, in the past, we used to implement like co-payment of 30 baht. But later on, we found out that the administrative cost of collecting and checking the money is much more than the money that we collect. So that we cancel this co-payment. And third, capitation gives provider flexibility with a prospectively allocated budget. They can invest according to their local needs rather than being constrained by fee schedule rules or audit requirements, so that they can use that money to invest in something that they think that it's really matter. to take care of the patients in the catchment. But it also presents some challenges as well, which require appropriate safeguards. First, capitation may incentivize under provision of care and referrals, potentially harming patients who need specialized service. This is the real case in Bangkok, and it's really painful. To address this, the strong patient protection mechanism are essential. In NHSO, we implement the 724 contact center to protect the right of patient and also allow flexible registration for full time per year so that patients can select the favorable clinic and the money will follow the patient and promote competition among private provider. Second, capitation may encourage cream skimming behavior when provider avoid high-risk patient. For example, in the case of Bangkok, many private provider will like tell the patient that they were gonna close the clinic. They cannot refer the patient to the tertiary hospital by this or that reason. And then when the patient's fed up with this kind of behavior, they move to another clinic. So the risk move to another clinic. So you only have a cream in your clinic. So you get a lot of money from that. This requires timely regulatory enforcement, including contract monitoring, formal warnings, and if necessary, terminations of the contracts. Third, capitation may not always work for certain services. For example, in Bangkok, we used to pay capitation for preventive and promotive service. But later on, we found out that even they get the money, they did not provide any service, preventive and promotive service. So that later on, this money is, they change the way of payment from capitation to fee schedule instead. Yeah, because otherwise we will lose the efficiency of the money that we have. However, this kind of capitation for PNP service still exists in all rural area of Thailand except for Bangkok because yeah, it's pretty difficult to manage a private provider in Bangkok. Next, we're gonna explore the DRG system. Initially, the DRG system was introduced to the NHSO in 2004, and Thailand is currently on its sixth generations of DRG grouping, version 6.2. Now, if you look at the payment mechanism in Thailand, for our patient, we might use fee for service for the civil servant, and for the formal employee and all the remaining of Thai population use capitation for our patient. But for inpatients, all the three schemes use DRG system, but at a different modifications, like modification. For example, like the civil servant medical benefit scheme, they use multiple DRG. Fairing big hospital will get like a bigger base rate. But for the universal coverage scheme, we use single the base rate. But for the social security system, if the relative weight is lower than 2, they use capitation. And if it's higher than that, you use with the global budget. Yeah. And the DRG classify patients with similar clinical conditions and resource use. To ensure financial sustainability, NHSO funds DRG under a strict regional global budget. Once the budget is set, the payment per relative weight is adjusted to remain within the cap. So we are not just implementing DRG, but we also use global budget just to do the cost containment. So each admission is assigned a relative weight, but payment is determined by multiplying the relative weight by the regional base rate and a hospital adjustment factor. In Thailand, we have another factor we call K value on the right hand side. Yeah, this K value, it's a constant to compensate for more rural hospital. They will get higher K value because we have to sustain that kind of service even it is not profitable. Yeah, we try to allocate more to the rural area. So you can see that in our system we do a lot of reallocation. Yeah, at the national level, at the provincial level, or even between big and small hospital, we do some reallocation. And this is the history of DRG system in Thailand. For Thai DRG, we use the sixth version with around 1,500 DRG groups. So DRG provides a system with 3 benefits. The first one is transparency. For individual with similar illness, using relatively similar resource, the hospital should be paid with the same amount, and it can be rechecked by peer review. Yeah, we allow the hospital in the same area to recheck the record so that they will know which one is gonna do some creeping. Yeah, and it lead to effective cost control. And the last one is it incentivize optimizations of resource use per case of patient and promote efficient practice. However, there are some limitations as well. The first limitation is it requires organizational capacity and expert to appropriately reimburse by DRG. And second, there are inherited motivation to underprovide in terms of quality of care. Maybe they discharge patients quicker than it should be, or cause some readmission or split visit. So payer has to put in place claim audit and quality audit system in place. The most prominent gaming behavior is DRG creeping or upcoding, where hospital intentionally code secondary diagnosis to inflate their reimbursement. Thailand counters DRG creep through the establishment of regional global budget, which dilute the payout if everyone overclaim. Comprehensive coding audits, billing audits, and quality audits by NHS. So it's important to counterbalance the gaming behavior of the provider. And our recent innovation that we have use DRG to actively steer clinical behavior. We intentionally assign higher relative weight to one-day surgery or minimally invasive surgeries. This financial incentive motivate hospital to adopt these efficient practice, dramatically reduce average length of stay from 3.9 day per admission to just less than 1 day, freeing up hospital beds and lowering patient infection risk in the hospital. So yeah, we also have some example as well. I will touch a little bit on fee schedule, which is a pretty new one. So when we pay by capitation and the provider don't want to provide some service because it's high cost, so we might unbundle that kind of service to be paid directly by fee schedule. And we use it for like to increase some provision of some service, for example, like cataract surgery. And we also have some scheme we call OP Anywhere that accommodate the patient if they go to other province that is not directly related to their registry. They can still use the service under this kind of payment mechanism by fee schedule, but the payment is lower. Yeah. By this, I will go to the case that related to DRG and also fee schedule as well. So in the past, if we rely so much on DRG system and inpatient care, patients have to wait for so long to have the cataract surgery. So we try to shift from DRG system to pay by fee schedule instead. And by that movement, we also do central procurement for the lens. Maybe here, we buy the lens with the much cheaper price by central procurement. And we also contract a private mobile cataract surgery unit that is like 20 times cheaper than the private hospital. And we can increase the utilizations of patient in 2004 from around 40,000 to 140,000 people. Most of them provide the service are provided by public facility, and you can see the increasing trend of private hospital. In the another case, when fee schedule hurt GP, in Bangkok, before we use capitation, we used to use fee schedule to pay. In the first year that we implement fee schedule in 2021, they reimburse for 1 baht, 1 point, but because of we have much more money than they claim, so we pay 1.85 baht per point. So it's a lot of profits, right? But later on in the fourth year, you can see that the service output grew like 140% from the previous year. So that the points go down to around 0.5 baht per point. It means that if you do the cost structure of the service by have a margin of 20%, So the cost is 80%, right? And if the point go down to 0.5, it means that you are in a deficit point. So yeah, so there is a lot of like protests in my office here by paying fee schedule. So by this event, we have to change suddenly from fee schedule to capitation, like in the half of the fiscal year. Okay. So all in all, I would like to recap about the accountability metrics of each payment mechanism that we have. So for capitation, we we as a payer have to make sure that the cost that we use to calculate the capitation rate is fair enough. For example, like do we do the sampling from every groups of hospital in Thailand to make it fair for every group, for example. And for DRG system, we need to calculate an accurate clinical weight. But for fee schedule, yeah, you have to negotiate and you have to know the real cost so that you can like squeeze out the efficiency of such payment mechanism. But for provider, by capitation payment, you have to focus on generic drugs, rational prescribing. For DRG, you have to reduce the length of stay, but have to balance with the quality of care as well. For fee schedule, the risk is supplier-induced demand. So we have to implement some kind of like pre-audit, maybe AI-assisted audit to flag uh, some transaction that it's skeptical, something like that, and do some like auditing. And for the patient risk, for capitation, patient in Thailand, especially in Bangkok, at risk of gatekeeping lock-in because the clinic won't allow them to be referred to bigger hospital and longer queue. Yeah. And for DRG, patient may face with like quality or shorter stay issue, but it's not that serious. For fee schedule, this is pretty like liberate for patient to use this kind of service. I think patient love it, but it is not good for the pocket of the country. Okay, let's go to value-based healthcare. So this brings us to Thailand newest frontier value-based healthcare. When we look at where to begin, we need a disease with high cost, high volume and high risk profile, but also with clear evidence-based treatment pathway. So in the first place, we look at many diseases that can be implemented by value-based payment. For example, like cancer, hip fracture, lymphedema, heart failure. But in this case, in developing value-based payment, we also work with University of Swansea. So we rely on the experience and expertise of Wales in the UK. They have like 70 diseases that they implement value-based payment. So we select only one, which is a COPD and asthma. And our target population is around 1.5 million Thai population. And in development of this value-based payment, we look to the previous experience in 2010 to 2015. We implement the initiative called Easy Asthma Clinic. We inject around 200 million baht to the as a bonus for clinic that perform very well in terms of like health outcome. And you can see the improvement in terms of like number of well-controlled and partly controlled asthma patient during that period, and also see significant reduction in asthma admission as well. So we plan it in 3-year stage. In the first year, we cannot say that it is value-based payment. It's just like kind of like a bonus payment to well-performed clinic. And for the second year, we will integrate PROM and PREM, which is a key indicator of patient feedback into payment mechanism, and also do the research on cost of the care across level of care and yeah, function of care, IP, OP, and PP as well. And in 2027, we plan to implement the full value-based payment for this disease. This is the pioneering project. But what we have right now is like the care pathway action and scheme and payment, which is pretty fragmented in terms of like payment. We have a lot of payment mechanism for each process. So what we have to do is to streamline care pathway and also payment mechanism. So this is the duty that we have left in this 2 year. So, okay, we will rate the performance of each primary care center by counting the IPD visit and acute exacerbation and ER, and we rate their performance. If the admission rate is pretty high, they will not get they will not get any like bonus payment. But if they can control the admission rate and exacerbation at ER by good follow-up and regular care of patient in outpatient setting, you will get uh, one time if the admission rate is lower than 0.5 SD. And if you do better than that, you'll get 2 times payment. So, and we also integrate PROM and PREM, which we use maybe COPD as assessment test and asthma control test as another way of measuring health outcome of patient. And it will be integrated into payment in the future. So yeah, this is all about value-based payment, and we try to do this without increasing any additional burden to provider, because we will use the existing data, for example, like admission history from the central database that we have, just to calculate the additional payment. And okay, here we have a source of KM that my office did around 33 books right now. So you can study from these books. Yeah, and you can scan the QR code. This is all about payment mechanism and strategic processing here in Thailand. Thank you so much.
Thanasak. So I think the clear takeaways from your presentation is one, that we need not spend a lot, we spend better. We need to build capacities, long-term capacities. You have very beautifully uses blended payment techniques, and you have learnt on the way. So what didn't work, you moved on. But more importantly, it took almost 20 years for you to move from utilization to now started measuring outcomes. And so thank you so much for this grounding presentation. To wake up everybody who's sleeping, we'll do a small poll. And I'll request that we have the poll. But in the meantime, as the QR code gets screened, maybe Dr. Thanasak, just one reflection on what should India's first priority be to move towards outcomes. So you can take 2 minutes. In the meantime, I'll request everyone to download the QR code, give your responses. It is essentially to see where should Indian states start their journey towards value-based purchasing under PMJ. There are no right and wrong answers. We are a diverse state, different state. And let's see what all of you feel.
So when it's come to value based, my boss will say that we have to not just look for only high value care. We have to look at the care that we have already exists in our benefit package that might be of low value. That's one way. But to do high value based healthcare, you might look at some country that have like good implementation. For example, like in Thailand, we consult with the UK, so that we learn a lot from them in terms of like how they implement it. They even try to translate like the prom and prem into like local dialect. So I think it's pretty good to have a friend to work together in terms of like developing value-based healthcare. And for my office also, be willing to like work together with India as well. Yeah. And last but not least, I think that out the key message might be in slide number 6 about the strategic purchasing role, because you can use it as a guideline to look at each component of strategic purchasing, whether you have done this already or there is a room to develop more. So yeah, we can use that as an assessment tool and then implement something that, yeah, may be favorable to value-based healthcare.
Okay, great. So let's see, do we have the poll results? Okay, so almost close to 50% people feel that we need to strengthen care pathways, primary care, referrals, and follow-up after discharge. And I think that's a big take home, because the Ayushman Bharat reforms are meant to create that continuum. So thank you so much for everybody for participating. Now we'll move on. To exactly what Dr. Thanasak said, in 2022, National Health Authority came up with the value-based care policy. and it imbibed a lot of elements of what you presented. It started with focusing on incentives and not payments. It spoke about patient satisfaction, capturing prems, looking at grievances, and of course, it was a forward-looking policy. It is still at a policy stage, and the implementation is yet to begin. But I think it will be great from to hear from Dr. Pankaj Arora what were the key elements and how do you think we can initiate this?
Thank you. A very good afternoon to all of you. And thank you, Mani. Excellent presentation from Thailand. Good work they have done. Unfortunately, we are 20 times their population. So it will be slightly difficult and it will take slightly more time to reach to what they have done in 20 years. But yeah, in the last 8 years or so, we have done a bit. And as a person, as a doctor, as an Indian, I see that uh, there's a tremendous change which has happened over a period of these 8 years. There was not even access available. Accessibility was a problem. We are talking about right now the value based care. The volume was a problem earlier. So we have done a bit through this through this program. So before I go on to explain you the what we did and what we are going to do and what does the value means to or the value based care means to us, I'll again welcome Thailand National Health Security Office here, and thanks for the nice presentation, Himani, Vineet, my friend Archana, Dr. Mahesh, and dear friend Sudhaji, and my friends from research background and a different part of healthcare. And ladies and gentlemen, welcome all. And we in 2017 came up with a policy first, which was a national health policy document, which thought of giving healthcare to all. First of all, it was difficult. Otherwise, there was a public sector which was available. The funding was tax based. It was totally free, no capitation as such, and the target was to give equity, good quality healthcare to all. That universality was to be reached, and we were just going on the agenda of the Sustainable Development Goals of 3.8, giving the universal health coverage for all. Out of this national health policy came an amazing transformative healthcare program named Ayushman Bharat. And that's not only the PMJ, which we are talking about today. It had 4 pillars. The first one was the most important one, which is the primary health care available at the doorstep of the human, which is there, the Indian, the person who is an Aam Aadmi, or for that matter, a common man, who is not even having that amount to take medicines and purchase medicines from outside or have that OPD care. So we developed now 1,80,000 Arogya Mandirs, which are sub centers, which are the primary way to get that circle completed, which you one of the poll option was to have that care pathway. So it has to start somewhere. So 1,80,000 is a huge amount. We have 776 districts or nearly 780 districts. To have 1,80,000 health and wellness centers is huge per district as such. And thankfully, we have achieved it. So that's one step to add the value and have that value based outcome. Followed by the amazing infrastructure and a public private partnership initiative by the name Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which takes care of the second part of it, the referred part of it, the secondary and tertiary care. That was the main cause of the catastrophic health expenditure which we were facing, and there was a lot of out of pocket expenditure because of that, and several people went into poverty. Nearly 3 crore or 30 million, you can say, went every year to poverty recently. But it has changed that thing. Now you can go to any hospital, public or private. If you are having that card for the marginalized, it is free. Now comes the continuum of care which needs to be developed between that ARM and ABPMJ. Before I go on to that continuum of care, the third one was addressing the gaps, even with those centers, to have the facilities available and infrastructure available through the Ayushman Bharat infrastructure mission, the health infrastructure mission. To have that increase in the facilities available at everywhere, at every part of the country. And finally, which we have developed, an amazing digital mission. I get goosebumps when I talk about it. It's really amazing. You can't even um, imagine that thing 20 years back. Having all your health records in your mobile. Everybody is nearly having a mobile, and it has. We have learned excellently from the UPI, which has been adopted so well, that we are going to go to this journey and adopt that digital health record journey also with us. So these are things which we had to create kind of a circle for even thinking about the value-based care. Through the Pradhan Mantri Jan Arogya Yojana, we catered a part of the insurance. You have excellently shown the financing models of capitation, fee for service. We, in this, I have a case-based payment method. The case-based payment method helps us to have a single package for a disease and really curbs, not fully, but a good amount of fraud or upcoding. It cannot be upcoded usually because there's no line item which can be added, no fee for service. But definitely we have a fee for service system for our civil servants and the government population through different schemes like CGHS, armed forces, paramilitary forces, railways. We take care of 2 to 3% of the population through that. A good amount of population is covered through the financing model of Social Security, through the Labor Department, which is nearly 10% of the population, 13 crores to be exact. Again, we have kind of put it on the same platform of PMJ, and the rest, 12% are having insurance from the private sector, 30% are still missing it, and they are using that public funded public sector which is available to them. So this case-based payment method, what we are doing, we are covering nearly now 55% of the population. Earlier, we had marginalized and impoverished people. Now extended it to the healthcare worker at grassroots level because they are doing the excellent job there and they need that cover and be safe in their mind too, that they should not worry about their families. And then now the most important ones, which are elderly, which are usually marginalized, not thought of, but yes, they are marginalized. The children are not there. Even the spouse sometimes is not there. Nobody's there to take care of them. So we have provided the healthcare for them also. An amazing, or rather, 2 or 3 amazing things about the scheme, which I think you should carry. You must be knowing most probably because Thailand is well aware of things going around. Sometimes India is not, but we cover everything from the first day. All these are covered. There is a coverage of 0.5 million of rupees in Indian currency, and person can take treatment anywhere in India. And with such a large population, 60% is a good amount actually, the number of people. And we have given nearly 110 million treatments in last 7 years, amounting to nearly 17 lakh million in currency of Indian rupees, as well as a lot of portable services with a very small cost per capita, only 13,000 per admission. Now coming on to the topic of today, this was just to set in the context of what we'll be talking about. NHA National Health Authority thought of it that we should not only deliver care but quality care. And several things were designed, and we did several interventions to help that quality drive being there. One was through empanelment process, which was through several guidelines which we had with set quality standards, with number of beds the hospital can have, the defined HR, the doctors that they should have, the facilities in infrastructure of the labs, of the radiology and emergency services. That gives the outcome in a way of quality from which we can build on further. We also incentivize the quality through the certification process, and if the hospitals are certified, we incentivize them over and above the packages. We also in few state till date, three state rather to be exact, um, 2 years back, Delhi, West Bengal, and Orissa had only hospital which are quality accredited get empaneled. But because of the demand through the time, we have allowed other hospitals. Going forward, we also in last 3 years, 4 years back, so Dr. Sudha was there. They designed an amazing health benefit package which had covered the rates as per the tier of the city, because it really needed to be reimbursed at the level of the infrastructure they need to develop and the HR they need to have. Definitely, in the rural area, there's a issue of the reservation cost, but yes, the infrastructure cost and the HR cost in the higher tier city is there. So they devise the package according to that, and they revise that periodically over the last I think 6 to 7 times they have been revised. And these were the initial parts where we designed things for the quality assurance. And for decades, since we have been giving healthcare, we always thought about the volume-based care. How many tests have been done? What procedures, number of procedures have been done? How many admissions? So that what we are doing right now. We are paying the persons, the hospitals, the providers on volumes which they're doing. And we have never thought what was the result of the patient who's coming out earlier, not now. We have done a bit of it in the time before even the value based document came in place, and still it is in policy level. But yes, the things are in place which check the readmissions, which hospital is doing how many readmissions, and several other things. So to shift from this volume based care to value based care is important as of the topic of today, because we need to have a better health rather than number of patients getting treated. Access we have achieved in a really, really good way. I've seen a patient coming with nothing in his pocket in the medical college, and his children's crying in 2006, like 20 years back. It's in front of me. It has happened. They have nothing. We had to arrange things from them, and nothing was available in the sector, government sector also. It has dramatically changed. So now what we have to ask, that are the patient getting better? They are getting treatment, yes. But when they are discharged, are they better than when they came? This value-based care challenges the paradigm of only just the treatment was done, but it asks that have you made me better when I went out? So it shifts the focus from how much the care is delivered to how well the patients are doing now. It's really, really difficult because, as I said in the starting, we are 20 times the population of Thailand, so it will take much more time. But here, the healthcare provider, if we go forward, will be rewarded not for quality only, but for outcomes also, for improving the patient health, reducing the complications during the admission, enhancing their quality of life, and ensuring that that patient goes out satisfied. Because if there is a feedback loop, if he doesn't say that he was satisfied, you will get less payments. So what does value-based care give us as per the document we published, or as such, what it has in inside it is that we get the best possible health outcomes at an optimal cost. But it's not about cutting the cost only, or maybe enforcing the compliance. It is maximizing the outcomes not only for the patients, but for the providers and the payers. The patients get the advantage as their health outcomes improve and they're satisfied that I have been treated well. And providers get the benefit by enhancing the efficiency and the clinical effectiveness of the treatment they give. The payers, as government, or for that matter, even the payer who is paying itself, they get the better returns on the healthcare spending. And the most important thing which the value-based care deliver is the betterment of the society's healthcare, improving the overall health of the population. So it aligns incentive across the healthcare system. So now, what we have done as NHA, we have done a bit, as I said, we had changed that payment methods from fee for service, which we had earlier, to case-based payment methods, which was very difficult because providers has to be onboarded for that. Stakeholders involvement is important. If they do not accept it, it will not going to work. But yes, definitely the strategic purchasing and collective bargaining helped, and we purchased the services at really good rates. That's why the expenditure per capita is less. Through another initiative of health financing and technology assessment at National Health Authority, we calculated the new tech. We kind of evaluated new technologies, uh, kind of saw their effectiveness, clinical effectiveness, and the cost effectiveness. And we bought the services as per the value they would deliver. We are assessing the performance of the hospital at present already, which is also to be done during if we go forward through this value-based care, through evaluating how many hospital admissions are being done again for the same disease within 30 days. That is the readmission rate. By calling the patients, we always have a call on the second day and the last day of the month when they discharged to see if they have got the medicines, they have been treated well, and if they've been admitted in this month, so that we calculate the readmission rate through that, as well as seeing if they are being charged anything which is otherwise free for them, or were they financially protected or not? Was there any out-of-pocket expenditure? Strangely, in 2023, when I did this exercise of calling these people through a call center, and we evaluated the calls, we already designed questionnaire. The satisfaction rate was 99%. Still, there was 8% out-of-pocket expenditure. It was several things, including the travel cost, which we further in few states have incorporated to their system. There was something charged for even shifting the patient from one place to other. Of some part, they're saying that this package doesn't contain everything. We have to get some investment. It had everything, but yes, still the patients are happy because nothing was available before that. There was an issue of even available healthcare at that time. And finally, that quality will improve when there is a circle complete through the pathways from primary, secondary, tertiary, and the backflow of the patients back to the primary care. So, this Arogya Mandirs, Ayushman Arogya Mandirs, have come a lot, have made us come a lot forward to get that pathway completed. And the most important thing, which I said earlier, the Ayushman Bharat Digital Mission, which has created a single ID and has created the IDs for the professionals, including doctors, nurses, pharmacies, as well as the registries for the hospitals, hospital facilities, and pharmacies. What it has done, it has given us the advantage of carrying that record with us to the back to the primary healthcare. So now, if we take this journey together as a full journey, it is complete with the continuum of care being available, patient being referred from the Ayushman Arogya Mandir to the Ayushman Bharat PMJ hospital and back to the Arogya Mandirs. And this digital infrastructure helps us to have that seamless patient records with us, as well as the better coordination of care. And also, it gives us the data which can be used to create policies for the population. So we require a fundamental mind shift for that. Actually, not only policy can change it, but people have to be changed in the mindset, the providers specifically. And we should not ask now how many patients we have treated. We should ask how many patients have actually got better. Instead of focusing only on the process, we must also focus on the outcomes that matter to the patients, their ability to live healthier and having a fuller life. Finally, the provider should not ask like only that, how are we? Did you like it? How we treated you? But they should ask, how are you? And this should be the way the patient will be truly having that center stage, and it should be a patient-centric care with that value base and the value added to this journey of that patient. Definitely, the transition will not be easy. Third time I'm repeating, we are 20 times you. So it will take time. But yes, we will be there with you in some time, because government is really, really there to put its foot forward. And the budget, we talk about the WHO cube. We have grown on all sides, increasing the number of people enrolled. Expenditure has gone 4 times in last 4 years in front of me, as well as services have gone from 1,300 to 2004 earlier, now to 2,400 in the time to come in this year. So it will be difficult, definitely, because it's difficult to measure the outcomes accurately. As you said, the stakeholders need to be having the capacity, as well as the government, for checking the frauds, uh, ensuring robust data systems. We should have that ability to have that systems available, and we should be there building provider capacity, as well as aligning incentive across the stakeholders for this value based. So what the document design was shifting that quality incentives, 50% of that, to the value-based care. 15% we give for quality accreditation. So we can give 7.5% for the value which a patient takes. And we can evaluate with several scores which are there. European score is there for seeing what quality he had or she had during entry to the hospital, how he exited or she exited after treatment. We have a clear direction by shifting from volume-based care and only the quality incentivization to the value-based incentives. We will be giving this patient-centric care more, and will have an amazing, healthier India. And from the learnings you have given us, amazing things which I've seen in your slides, I think we have to prioritize the conditions first. Few of them you have done with asthma, COPD, again a difficult one. Huge upcoding is possible. I can say I'm having acute respiratory, or the hospital can get involved in me and have that attack there, and then you can be charged. But again, amazing system of capping it we have done. So great learning for us. But we should prioritize one or two conditions to put the pilot on again, and design a common outcome indicator framework for that. Definitely, you have to take the stakeholders on board, develop their capacity. As per the slides you have shown, it's an important thing. And we should leverage the systems which we have, the data sets which we have as Ayushman Bharat, unimaginable data sets actually, and as well as the digital health infrastructure which we have. We can leverage that to provide this value-based care, and end up having not only access, but amazing healthcare delivered to our citizens, and have a healthier India. Thank you.
Thank you, sir. I'll repeat it one more time. We are a very, very big country, but we can start small. And I thank you, sir, for making that point. And I think you sit at a very important intersection. Now you oversee the digital mission, which needs to integrate with primary healthcare. So, sir, we will work with you to see how this integration is possible. Thank you so much. We'll move on to our state experiences. One of the states that has consistently been on forefront of strategic purchasing is Tamil Nadu. With a long history of publicly financed insurance, strong provider management, and early adoption of quality linked approaches under the scheme. We have Dr. Vineet with us, who's going to make a short presentation, and then we'll have discussion after that.
Good afternoon to all. So thanks to the Access International and the other all the organizers. So I'll just jump to the Tamil Nadu experience on how we have been handling this lessons in the insurance sector. First and foremost, we had started in 2009, a long back, and the time. So we had huge learning time whereby we could fine tune the program. In fact, DPH, the earlier DPH, he was there for a long time in the TNHSP during the insurance times and has helped from a lot of the components and the empanelment process. So one of the most important factor which Tamil Nadu believes is a very strong public infrastructure. So though we do the PPPs and also the insurance and other private-based models, we continue to invest heavily and in fact aggressively in the area of public healthcare, in the sense that we try to see that every district has a government-run medical college. So that is one of the major policy taken by the government, and we try to see that tier 1 institutes, we have now around 15 to 20 in the government sector. We would like to see that it goes that is within a radius of around maybe 100 kilometers. There could be 100 to 200. There is a tier 1 with a neurosurgery unit. So that's a kind of trial we are doing. And in between, we had to accelerate it, JICA and World Bank funded projects, which also built upon this system. So the why I am saying this as an starting point is that almost 50% of the income which comes from the insurance amount falls back to the public system, and it is flowed back for the concerned medical fraternity to use. And we have given considerable freedom. There is no need for any government order or anything, which I think is one of the unique features of Tamil Nadu, that a dean or the HOD has the entire power to spend, maybe it's 5 crore or 3 crore without any government approvals, to ensure that they get the freedom on what to spend and where to spend. And we believe that decentralized system and not getting into nitty-gritties on saying that paper is missing or this is missing has helped the system grow in a big way. Another thing, I'll come to the insurance part more, since the discussion is more on that, is that we had made certain exclusion criteria consciously. Say, fever or even total knee replacement or hip knee replacements, where there is an demand that can be induced by the provider, we have consciously kept out of our system. And also very simple items which could be easily misused, and probably the cost of catching them or analyzing them would be far higher. So that is something which we have done. So many procedures which were already, what we have done is we have seen the counterfactual as to what would have happened in case the insurance was not there. So probably they were all getting treated at a very lower cost, and we tried to find out the cost of that also. Say if it's a 200 rupees procedure, say a fever, so he may be, or a 500 rupees procedure, we did not get into making it an entire packaging, so that that processing charge and everything. Instead of that, we funded it through the public infrastructure to reduce that cost on our the insurance system. Another thing which we have tried to see is that the cash flow is given heavy importance. So we see that irrespective of whatever happens, we pay the hospital after 7 and not later than 10 days. So this gives them a not the value of the money, but that is the huge size of money, or but they always expect a timely payment. So this payment, neither by citing an audit reason or anything, we try to see that this cash flow is maintained. And since the presence of the government hospitals always has had an anchoring effect. Say, for example, the rates of CT was exorbitantly high long time back when the insurance schemes started, 4,000, 5,000 or. But now the Tamil Nadu, even private offers 1,000 rupees offer much, if sometimes even 500 rupees lesser than the government, which is at 1,200 or 1,300, to see that they achieve certain volumes. So, so this is something which we have tried, that an anchoring effect. Mostly it is said that the government could be inefficient and all, but this gives a huge anchoring that there is always an option for him to go and do an balancing act, that there is a government facility nearby. That is one part. Another is that which we have done in is the procurement methodology. So Tamil Nadu has an agency called Tamil Nadu Medical Services Corporation, and they are one of the few organizations which have posted all their rate contracts openly for any states to. Generally, it's very difficult for a government document to be seen by someone. Though their website, any state government can see, and in fact, many governments during opening their tender go and see the TNMSC or the Tamil Nadu Medical Service Corporation rates to see that at least they don't get into an tomorrow an vigilance inquiry because the rates are too higher than what is quoted in Tamil Nadu. So this openness on the procurement, whether it's right or wrong. Sometimes the rate could we would have gone wrong, but we say openly that this is the rates we have arrived and this is the volumes we are expecting, and generally it's not related to the volume, not the volume. So the otherwise the supplier would run to get match the volumes. So we try to see that that is presented to all and everyone is able to get that. So private also gets a bargaining power to get that. Another thing which we have tried to do is, while procuring, is having a comprehensive AMC and to have procured things which are on having an open cycle. This is something which we recently have come with. Earlier, we used to have only very short AMCs, 2 year or 3 year. But now we have demanded that at least there should be comprehensive AMC of 7 years. So all the machineries run, that is without any headache for those years, by which the depreciation would have caught up with that, and probably we may not need that device anymore. Another thing which in fact we have tried is also the turnkey aspects. So in setting up, so when we set up hospital, say something which is very complicated, generally a fight goes between different wings as to the electrical, the civil, everyone, that they did wrong, so we couldn't complete it. So maybe the cost may be slightly marginally higher. So CT, MRI, everything, we generally go for a turnkey method. Recently, what we have been studying the health benefit packages and also other rates of other states. We had done an exercise to compare with and match it using just an to the software R along with a fuzzy logic. We could see that there are huge variations across the rates quoted by various states, and probably there's a need to intervene. In fact, strangely, we found that one of the urology had a very high lower rates quoted for whatever be the reasons in certain states, while something related to or nephrology probably would have had a heavy outgo. So these anomalies probably which may have come up during the working of packages is probably what we are trying to work out while we prepare for the next tender. And recently, we also came upon the PPP model of Telangana, whereby they could achieve a very nice, good rates for the dialysis for a long term, which I feel we are also on the path to explore it and had done few tenders to discover the rates, so that single dialysis can be made as a policy at a cost lower than probably the earlier multi-use dialysis. Another experiment which we have recently come across, and we are trying to implement for having value achieved is the Mizoram has been having a model whereby they combine various items of insurance. Now, insurance is like there will be an EPFO or someone, or the labor department may be having something. Then state may have for pensioners, employees, some other schemes. So an attempt probably to cover through a universal healthcare in a manner by which the patient outcome is kept as fixed, while the quality of outcome, say the color of the bed sheet or the quality of the TU, may be something which is an addition to the which may be seen as a part of quality. However, the patient outcome, where what the medicines are used, what the treatment protocols are maintained, could be seen as something which is part of the patient outcome directly. So that patient outcome is something which we have been now concentrating on, and rather this so that we achieve value in that. So we try to see that these are not mixed at least, and then so and next is the accessibility, as sir is heading the digital health mission. The same we have been trying to make the M1 M2 compliance, so that, and the M3 compliances, so that the records can travel very safely across government to private, and wherever the patient wants to. We feel that that will have a revolutionary impact in the way patient seeks appointment and also takes care. So those all our apps, website are in the process of transforming to this, so that they will be able to you would have earlier heard the model of care coordination model. So this traversing through the health system would be made much easier and simpler, while we integrate with insurance along with the digital health mission. So that is the journey which we are traveling. And to end with, we have also included something called high cost procedures, that is, which are rare in nature, but the cost is exorbitantly high. Those are catastrophic expenditures, like say liver transplant, renal transplant, and all. So the insurance and the state supports it exclusively by setting up a separate fund from which the poorest are and the needy are given these treatments. So that has been a success, marked by the fact that transplantation, if we take the cost in certain cities, it could be 1 crore or 2 crore, and but the same thing can happen in many, for at least a large number of patients covered of poorer background, at a predetermined cost, at a controlled cost. And we have seen that the private partners are also very much forthcoming, and they see that all other external or whatever which earns them a huge revenue are sometimes left, and they just take only the cost price. So this is where our insurance model has been doing something better. We look for something called invoice cost and not the billed cost. So there is a marked difference in this. And we have our total outgo is only around 1,450, which for a similar sized state, mostly, which when we compare is around 3,000 plus or double. The reason being that the build cost is almost always double or triple, and we see that the invoice is checked, and we have always during the empaneling also told that it is up to you to get a better invoiced cost, but we'll pay for whatever is the incoming. So this marginal costing principle, which the for long the Tamil Nadu has been following, has also been helping in its service delivery to a large section. So with this, I end my discussion on it. I see that there is a slide also sent. So mostly this is just the evolution which has happened, and also something on the quality aspects and gradings. This is something which is part of mandatory NABH entry level. In fact, another thing which probably I will be slightly distancing from the whatever the popular opinion is, that we feel that the quality has not been a great, like when we see the utility of it at field level, slightly it's questionable, because the checking happens once in a while, or maybe once they pass that poll of testing, probably next day they may not keep up with that. So probably we need to rework our thought process on quality on, and also sometimes it's really difficult, and we feel that some are very not really oriented towards the patient outcome, but engineering aspects which lead to rejection of hospitals getting some of the decorated certificates. So we have not been a heavy fan till now of getting them NABH or whatever on that. However, we do a strict infrastructure checking, especially in the sense that they own the equipments, and this is validated through an on-site inspection, because we see that otherwise they keep at one place and then take to another hospital. We see that the billing is in their name and not towards their sister or brother organization in another hospital, and suddenly they just shift it to this location just to get it accredited and then take it back. So these are the few simple things which we have done. So these are the general scoring criteria, I guess. It is known to it, and that's it. So the negotiated pricing in various forms have happened, and mainly it is through the TNMSC. That's all. Thank you so much for the opportunity.
Thank you so much. I think what you have broadly focused is very, very strong and effective governance, transparency shaping provider behavior, and also initial steps of really, either looking for accreditation or hospital grading systems, which are initial steps for quality. So when we come back, I would definitely again like to nudge you a bit. If we have to start measuring outcomes in context of Tamil Nadu, what could be one or two conditions which you think could be a beginning for Tamil Nadu? But later, right now, I will request Archana ma'am to please come up. Again, UP implements PMJ at a very, very unprecedented scale. I think 17% of the total population which is covered by PMJ is serviced in UP. So that's a huge population. And also there is a lot of interesting work which we have spoken about in terms of convergence, in terms of really identifying conditions and populations which are high impact. I think she's been leading a lot of work on that. I'll invite her to give a brief presentation.
First of all, thank you for giving me an opportunity to come from this state, because otherwise we are always in a firefighting mode and we never get a chance to go here and there and listen to the great ideas which I get to listen today. And the presentations which were shared initially and the thoughts which were shared. So that gave me a lot of brainstorming. I was not having a pen, so I couldn't write, but I had noted a lot in my head. So I think I'll be working on a number of things which I had heard from Tamil Nadu as well as from the Thailand official. And Pankaj sir has been always in touch. So thanks a lot, Himani, to give me a chance to come here and share the panel. I will not take much time. I'll start. So first of all, I would like to give you a brief idea about how we are working in UP. UP is one of the largest implementer of this scheme, which is PMJ, which we are talking about, and around more than 9 crore. It's actually meeting around 10 crore of numbers, and we are covering more and more people. Right now, what we are thinking that we will be moving towards universal health coverage soon, because rest of the people are already demanding to be covered under the PMJ scheme, because people which are covered by PMJ, other than that, there's a state scheme which is covering the remaining people. So there is a big number, which is still remaining. We are working on that. If we talk about the numbers of the hospitalizations, then we have already done since the implementation of the scheme since 2018, around 90 lakhs, 9 million hospitalizations. And our hospitalization, the average cost is around 14 to 15,000. So the claim which has already been paid is around 15,000 crore. That's a big number. And the checking of these claims, the auditing, the empaneling itself becomes very demanding task, and then continuous audit, as my predecessors were talking about. So it's a difficult thing. So now I'll focus, because I'll focus upon the value based system, as we were discussing, that now we have to focus upon the system which is not only about the utilization based, but about how the outcome is coming. So, in this presentation, I'll discuss about care coordination model, which we have discussed, which we have implemented in the last 1 year or more than 1 year. Our digital innovations, which are focused upon the grievance redressal of all the stakeholders, and the convergence, because we all know that the public health system is already working in various fields, and how we can actually um, connect with them, how we can actually support them, because the purpose of this whole system is to provide a better and healthier state or a country. So how do we do that? So and the last thing will be the our population, like how do we ensure that the outcome which is coming is equitably shared among the population which is actually vulnerable, like the women, the newborns, the children, who are otherwise not getting enough benefits of any scheme until we target upon them. If we talk about the hospital network, it is already 3,000, more than 3,000 private hospitals and 3,000 government hospitals. It's a big number, but I must say that we are working on the quality. Just before I came here, we were discussing about the quality issues, that how do we ensure, because once, as the fellow officer from Tamil Nadu, he was saying that once anyone passes the test, the next day they are moving towards the slippage, and you're never sure that how do we audit them continuously. So quality is one thing which are we focusing right now, and how do we do that? It's still a question, that there should be a short model where you can ensure that the audit which we did last day, and the concept which we were given to them, the standards which they are bound to do, are still maintained when they are raising the claims. Similarly, if I have to talk about the citizen empowerment, we are ensuring our care coordination interventions, in which we ensure that anyone who is there and getting benefits from a primary healthcare system, or even a secondary healthcare system, when they come to us and when they come to a EHCP, they get treated, and after that, when they go back, there is a strong networking between those two. Like anyone who wants to take a benefit from a PMJ hospital, first that person should go to the primary health care. And in case that that need is not met, like when we see our claims, many a times we get to see that there are people who are going for IPD admissions for dehydration, for fever, for unknown fever. There are various packages which I feel personally feel that that may be upcoding, that may be conversion, or that may be just neglect. So you never get to know. So you have to provide a very strong care coordination network, where a person first go to a primary healthcare system where there is a free treatment plan, and they get referrals, they get proper medicines, and if it is not catered, then they only go to IPD treatments. Similarly, we have to talk about the program converges in this slide. And in the end, I'll talk about the zero tolerance for fraud, and how we are working on it, how we are working on the behavioral aspects. So the unique thing which we have done is, first of all, to know that this is our patient-centric system, and we have to empower our citizens. For that purpose, we have a 24/7 citizen support system, that is with all the SHAs, I'm sure. But what we have done, that we have simultaneously launched a app, that is Sarathi app, where we are providing the enlistings, that what are the hospitals which are enlisted, and what specialities are there. Because what happens many a times, that if as a citizen, as a Ayushman beneficiary, I go to a hospital and ask for a certain treatment, sometimes the hospital say that no, I'm not enlisted for this specialty. So if you are aware, then you can actually ask for your rights. So this is one thing we are trying to make people more aware about this app. And parallelly, our call center is there for everyone. You can call as a hospital, as a beneficiary, and from that call center, you can not only get to know about the hospital, but you can also get appointment. For this appointment program that we are doing, because OPD is not covered in Ayushman scheme. So what we are doing that we are trying to motivate hospitals to come to our model, where they can actually give either zero payment appointments options to the beneficiary, and then they can give a subsidized option also. So what happens that people are choosing it. Yes, sometimes there is a we have to motivate them a lot. But what happens, because there is a strong chance that many a times people will get to go to the hospital, to that hospital only, so they are trying to come to our system. We did analysis of this, and Access Health has been a partner in this, so I must congratulate them also for doing this. Because when we did the analysis, we found that most of the appointments were booked by women and by the elderly. So I think this is a opportunity which you give to the people who otherwise don't want to go to the queue, go and stand there, because we all know that our hospitals are overburdened. So this is a slide where we talk about the how we are doing it. And what we do, that after appointment is booked, after an appointment is booked and a patient goes there, we also measure that if that appointment was converted into an IPD admission or not. And then also, when the patient was discharged, what happened to the patient. So what we are talking about, the patient based system, that if the patient was happy, if the patient got the treatment in a proper quality manner, we are doing this also. This on a very small number yet. These are not very big numbers, but we are trying to expand it. And I'm sure that this can be a pilot project. This can be a strategy. This can become a role model for all other states also. Because ultimately, when we'll talk about universal health coverage and a value-based system, patient satisfaction should be the most important thing which will matter. So we have a call center team which is trained for this, and we are doing this till now. Till now, around 1,300 appointments have been booked, and we are trying to bring more and more hospitals into the purview. It's a recent launch, so I think we'll be doing it better. This is the app which I was talking about. Similarly, we have a chatbot also. So we are training this chatbot continuously. This is a Ayushi chatbot, and anyone can go and on the link. It is hosted on the website of our state SHA. There you can go and you can ask question about your grievances as a beneficiary, as a hospital, as any stakeholder. You can go and ask. So continuous trainings are on, and we are trying to work. Similarly, about the citizen application I told about, that is also one thing which I think has been very useful. Because when you give someone access, someone an information, the person becomes very powerful. I have seen that people at night, many of my batchmates also have called me at night at around 11:30 and asked which is the nearest hospital where I should take my 70-year-old nanny or dadi or someone. So it actually happened to us. So this is one thing I think we can promote it, because Google Maps has made our lives easier, especially people who can't remember locations like me. So it has made lives easier for many people. We are trying to make it more and more popular. So now I'll come to the focus on the value based care. There's one issue in UP, not exactly issue. It was a conscious decision that we have C-section that is reserved for public health facilities. So what happens that most of the deliveries are happening in public health sector. Many a times what happens, if there's a child, if there's a newborn who needs some special care, then also they are not aware, because that newborn is supposed to be there with the mother. So most of the time, the neonatal packages are not being used. Even if someone has to take care of the neonate, then they do it in the public health facility. So most of the hospitals which are there for neonatal treatments, they are not using the packages. Moreover, the infra is also one thing which we are bothered about, because otherwise quality audits we do, and many a times quality audits are done and we find that people were not at par. But for neonates, I believe that the quality should not be sacrificed at any cost. So what is happening, that we are focusing on these, and we have instructed the DMs also, the people who are working in field, that there are certain common conditions which are found in neonates, like congenital heart disease, neural tube defects, etc., and which are covered in our scheme. And if they feel that their public health system is overburdened, they can actually consider empaneling more and more hospitals with these facilities. And we have launched a book for the ASHA worker who will be aware about these facilities which are nearby. Otherwise, we all know that ASHA workers are trained that they should not, ideally, they should never refer to a private facility. But we are giving them a open option that yes, because this facility is nearby and you can avail this facility here also in the public health facility. But if there is an overburdening, then the parent should be informed about the other ways, the other routes. Similarly, I'll tell about the convergence which we are doing with NHM. We have just shared that we have launched a book for ASHA workers, which actually talk about the basic facilities which are giving in the public health system. Similarly, through the EHCPs. The same thing happened with the RBSK package, because I have worked with the public health system also. So we all know that Rashtriya Bal Swasth Karyakram was targeted for early intervention for children, and if that is not done on time, then the whole value of it will not be found. So what happens, what we have seen in field in UP also, in otherwise also, we must have seen that when a child is referred to a DEIC, that is District Early Intervention Center, there's a big queue. And sometimes the child has to wait for 1 year, for 2 years, for maybe for more. So what we are doing, that we are calculating what packages are not being used, which are actually giving the same treatment which are given by RBSK. And then we are trying to tell to our field workers, to even the district magistrate, the CMOs, because district magistrate is the head of the district health society. So they can actually get involved in it and they can actually work better. So we are trying to tell them that these are the packages which you can use, and you can actually divert people if the public health system is overburdened, to these empaneled healthcare providers. This is one thing which we are doing. Then the same thing, we are trying to give treatment to more and more newborns, and the more and more people, more and more kids with the same disease which are otherwise covered in RBSK. For this, we started training our frontline workers, because it is very difficult to convince people that initially, when the whole public sector strengthening started, we had to train our ashas and our field level workers. No, don't divert people to private sector. You have to cater them in the public health only, and our public health system has actually uh, strengthened over the years. But right now we have to tell them that EHCPs are also there. If they are quality, if they are providers of quality service, you can actually send people to such EHCPs, because they are also getting free services there. And there is a very thin line where we have to you have to be very sure about the ethical referrals. So we are trying to do that through trainings. We did certain trainings with NHM, and we tried to did the utilization analysis and the provider network analysis also we did, to understand what are the supply gaps. Like I told you about the RBSK packages, neonatal packages. Similarly, there are other packages which are not being used, and then we need to have a targeted empanelment as well as the targeted utilization. And we were lucky that our ACS sir has made a technical committee where we are actually continuously working with NHM and PMJ coordination and the digital integration between the two, because what we have seen, that the data which is captured in NHM is not coming to us. Similarly, the data which is with us is not going to NHM. And ideally, what should be the system, as sir said, that ABDM is the pillar of the whole thing. But till we have all our facilities which are covered under ABDM or other digital tools, I think there should be a clear cut mechanism between the sharing of data between the public health facilities and the private health facilities, so that we get to know that the analysis which we are doing is actually right or not. Right? If my PMJ system is showing that there is a big utilization of cancer packages in a certain field, that should actually reflect in the public field also. So it is very much necessary that we have a clear cut interaction between those two systems. So we are continuously having this coordination mechanisms and meetings, and NHM is also supporting us for that. So, as I told you that what we are doing, because already Pankaj sir has talked about the various initiatives taken by NHA, and we are also in the line. The different things which we are doing is our work with the Rashtriya Bal Swasthya Karyakram and the SNCUs strengthening. Moreover, our work for improving access to specialized services and the targeted empanelment to ensure that the utilization is equitable. Similarly, the care navigation system through our PMJ support platforms like our call center, the Sarthi app, the chatbot. Moreover, we are talking about the quality of services because, as I have seen, when we talk about the more than 3,000 hospitals right now, I have seen that the quality is something which we have to continuously work upon. Initially, when in 2018 the scheme was launched, we had to force people and motivate them overtly to come to the network. Right now, we have a big network. I think the time has come when we have to audit and we have to ensure the quality, because it is our duty to provide Ayushman patient as good service as is being taken by any other person. Similarly, we have to, what is the way forward is we have to watch the treatment protocols. We have to ensure that anything that can be avoided should be avoided. Anything that can be dealt at the primary health center or even at a public health facility should not be coming to the IPD. And there should be a joint reporting system when both of the public health system and the private health system are talking to each other, and we can, in case of any doubt, in case of ensuring the audits, we can get the information from both of the systems. Similar, if I have to give an example, I'll give the example of the cataract surgeries, because we know that dengue or vector-borne diseases or cataract surgeries, we all capture that data through the public health system. But when we are doing that in PMJ, that is happening in silos, and there is no clear-cut interaction between the two. So we are working on that also inside our state. And similarly, the last thing is about using the feedback loops, learning from our peer states, and improving the quality and strengthening our accountability. So this was all. Thank you.
Thank you so much, ma'am. I think what she spoke about is what's going to be addressed by Dr. Mahesh, where Karnataka is again one of the only state which has gatekeeping. So you cannot go to a private without being seen at public, and then if required and services are not available, moved to the referral system. So I will request Dr. Mahesh to come and speak about specifically on gatekeeping. And again, we haven't reached to outcomes. We are still talking quality assurance, but if there is any direction that Karnataka is taking, we'd love to hear that, sir.
Thank you, madam. So I would like to talk about my state, one of the important initiative. Actually, that's a gatekeeping mechanism. We started that mechanism in the year 2022. And the gatekeeping mechanism is nothing but strengthening the public system and referring only needy patient to the public private system. So we have categorized all these procedures into, rationalize the packages into simple, secondary, complex, and tertiary and emergency. There is no as such gatekeeping mechanism for the emergency procedures. So patient can avail the treatment on an emergency basis without any referral mechanism. Coming to this, whatever the things, we have categorized some of the procedures that were simple secondary procedures that are that simple secondary procedure we have reserved only for the public. We are not giving that procedures to the private only, but complex secondary and tertiary we are going to refer for the private sectors. In this gatekeeping mechanism, we have improved the whatever the public system, and we have kept that whatever the accountability and the private system. This is about the whatever the gatekeeping mechanism and ORS. Thank you.
So we'll have one last presentation, and I know we are also running late, right? How much time do we have? What time? Okay, so I'll request Dr. Sudha. We did take some baby steps towards testing how to operationalize DRGs. And Dr. Sudha is going to briefly speak about a pilot that was done. And again, these are baby steps if you want to move. And after that, I will not have any questions, but I will request maybe 2 or 3 questions from the audience, and we'll try wrapping up, but I do want to give some time for the audience to ask questions. So please keep your questions ready. Thank you, Himani. And I would say that whatever you heard from Thailand, that was the starting point for us to think about DRGs. So I would say 2020 PMAC was when we met with the I would say architect of DRG, Supasit Sir from Thailand, and we understood exactly. He said one thing, it took him 7 years to convince his country to move ahead and take up DRGs. And he said, best of luck. So that was when we took it up at our level. And I think we took, I would say, 2 years to convince our government to say that, yes, we will explore it, we will consider it, we will, see how it works. Because it is not a system which is all experimental, because countries are doing it, and there are countries who are doing it for more than 15, 20 years. So it is not impossible, but it is something we need to put in concerted efforts. And that is how we began our journey in looking at with that one, uh, direction that, yes, go ahead and look at it. So that was when we did a lot of country to country advocacy, because our government needed to look at and understand how things are working in other countries. And we did that, and then we got the approval to do the pilot. Because it is not just say that, okay, this is the theory, this is how it works. And I think a lot of things look simple on the slide, right? But when you convert it into action in the field with the states, with the hospitals, with all stakeholders, I think it was a challenging effort, but it had to be done stepwise. And I think the first, guidance that was given for us to take it forward was, we did not have a coding. So our disease conditions, our packages were not being coded in a systematic way. And at that time, WHO was about to release the ICD-11 coding, which is a much simpler digital version than what we were using as ICD-10 as a backend process. So the first step in any DRG-based systems to strengthen or even to start was ICD coding. So that is when we took the support of WHO, and we were the first, I would say, any organization within India. NHA was the first to roll out ICD-11 in any of the ministerial departments or attached offices, what we would say. We were the first to try out and ensure a nationwide, there was no pilot. We rolled it out big bang once for all, taking the support of all the states, and every states were oriented, and a lot of processes was done at the back end with our own IT system, with the TMS, so that every package as and when is claims are being prepared, the ICD coding would also be initiated. So that was an important step for us to even do the pilot of DRG. So that first step, once it was done, we had to get the support of all the states, right? States who are willing to try it out, states who feel that, yes, let's take this challenge. And we got 5 volunteer states. I would say, if you look at from North, from Kerala, then we had the support from Chhattisgarh, Maharashtra, Meghalaya, and Haryana. So these were the 5 states who gave their consent to look at, and provided all the support in terms of ensuring orientation to their providers. And we took hospitals again voluntarily, took around 40 hospitals across these 5 states who are going to do and test these process, not for policy but for operational and feasibility. and also to understand what are the field level challenges so that we can see how to address them as we move ahead and take this forward. Uh, and another thing we also did was, because NHA was still a team which was still struggling with field level challenges, still looking at operational issues on a daily basis. So we had developmental partners who supported this initiatives, and I would say World Bank, WHO, GIS took up that initiative in providing the support to the states, because even states, it was a new initiative and states needed those support. So they put in the systems and legs in the ground in the states to work with the providers, work with the SHAs to ensure that the pilot progressed. And based on those early results, I would say out of the five states, we could complete the pilot in 2 states. In one of the state, we had to mainly look at discontinuation because of the change in the state policy, because the SHA themselves had some issue and there had to be a change in the policy. And in Haryana and Chhattisgarh, we completed, but we have yet to get the final reports from those states in terms of understanding how what were the final learnings from these 2 states. So I would say, based on the early studies and feedback, some of the issues that came up was, how do we ensure better support systems to our data entry issues, because that was one of the main thing was coding, because the coding was being done by the Arogya Mitras, and how can we help them, and how do we do the automation for ensuring that as the medical doctor writes the diagnosis, because primary diagnosis and secondary diagnosis are very important for coding. So helping the Arogya Mitras by ensuring that the doctor who writes the admission slip also ensures that he gives the codes. So that itself gets automated, and especially in single specialty hospitals and in hospitals which are most common condition, a ready reckoner would be the easiest way of ensuring that the coding happens at a much accurate level. And the second thing is also looking at, how do we ensure for DRG the case mix, because the hospitals, as um, my fellow friend from Thailand was saying, we have to do the adjustments. There cannot be a single flat rate. Currently, NHA follows a case-based single flat rate. But if you look at hospitals handling tertiary cases, the conditions are complex and the different patients are complex. So the cost doesn't remain the same. Some cases are simple, some cases are complicated, and they would use up more resources. So in that way, what is the kind of adjustment factor that needs to be prepared had to be worked out. So for the hospital, they had to look into how many cases, the complexity of the cases was again something they had to enter. And again, that would be more clearly taken up once the diagnosis is there. Once the primary diagnosis, the secondary diagnosis with all the comorbidities are mentioned, then you get the complexity of the case. And hence, when the complexity of cases are bigger, then the payment systems are different. You add on additional adjustment rates so that the flat base rates is, so that the patient care in terms of quality is also maintained, because many hospitals turn away burn cases because burns use a lot of resources and lot of funds are used in the first few days. And once the complexity increases, then there are more funds, and we pay, irrespective of complexity, a common rate. So they turn away after first 2-3 days. They say, okay, refer it to a government hospital. So the private hospitals also do case shifting, not just upcoding, as you would say, DRG creeping, but most of them do case shifting so that it goes to the public system, where there is, like, somehow they manage it till the patient is discharged. So these, also another thing is, we do not have a very good system of cost surveillance. We have the package cost, but most of the hospitals, if you ask them, they're not happy with the package rate. So they feel that it is not done scientifically, it doesn't consume all the costs that are needed to treat the patient. So that is why
Another system we built in was also to have a good cost database collection integrated within the TMS, so that the drug cost, the diagnostics cost are all captured individual patient level data, because that again will give you an exact case adjusting for the complexity, a good package rate, which can actually help in designing your benefit package better. So this is the first part of looking at DRGs, but the thing is also to come up with the DRG whole structure, payment structure, because all DRGs are not paid in a uniform rate. So there are DRGs where you classify them and pay them in a very appropriate way. So that payment structure we did not test because the first step was doing this, but I can draw in from the experience from Ghana where we did that, because they are paying the hospitals through DRGs. So we did the revision as part of the World Bank. We did a revision for their costs after 12 years for the DRGs. And then we could understand what are the complexities. And one of the key things that came up was having a proper standard treatment guideline and a clinical care pathway, which is very important to ensure a good DRG based payment. I think that is one learning. If we move ahead as a next step towards payment through DRG, that is one thing we need to align both the provider based levers for financing with quality care delivery as part of this. And I would just add in a few things about value based care or incentive payment, because that is the second part. Because DRG based payment does not limit to just paying for conditions. It also looks at if it is a readmission, if the quality of care is not proper, it will set criteria. If the patient is getting admitted or for the same condition or complication of the same condition, so how does your DRG work? So in that way, when you look at value based care thing, outcome becomes a very critical important thing. I would be very I didn't mention it, but many states can do this very easily, especially looking at mortality. I'm sure Karnataka is doing very well on that. They take a lot of initiatives in looking mortality in the health insurance programs, audits and morbidity audits and medical audits. I think these not only for fraud, because everyone thinks medical audit is only to look at fraud issues, but I think medical audit for quality of care is also very important, because when you do a root cause analysis, you can see where the systemic gaps are. And that is very important when you bring in DRG and value based care together. They have to go, whether sequentially or together, so that the best system of provider payment can be worked out. So I will stop here and take more questions on any of the pilot issues if there are questions. Thank you. So Stuti has told me no time for question. So I think I just will conclude. First of all, thank the panel for coming from all over the country and the world. And I think lots to learn. Also very heartening to see a lot is happening within India. Some of these things may not be very complex, but we can put our brains together and make it happen. I think few actionables is maybe we need to start small. I think the states where we support, we should be actively looking at what conditions we can support. Focus on care pathways. Payments are a little far away. See if we can start with incentives. But before that, also bring focus on measuring outcomes. I think audits are one very important way which we always underlook. I think that's probably also one place we can start. And maybe have limited scale pilots, learn and then scale. So with that, thank you to the panel for being there for 90 minutes and more. And we are very, very grateful. Thank you.